This is Dr. Peter Conrad of Vanderbilt University Medical Center in Nashville, Tennessee. I'll be discussing surgical options for the treatment of trigeminal neuralgia. The trigeminal nerve is the largest of the cranial nerves. Its name derives from the fact that each nerve has three major branches: the ophthalmic nerve, or V1, the maxillary nerve, or V2, and the mandibular nerve, or V3. The ophthalmic and maxillary nerves are purely sensory. The mandibular nerve has both sensory and motor functions. The ophthalmic nerve carries sensory information from the forehead, upper eyelid, cornea, nose, and portions of the nasal mucosa, frontal sinuses, and meninges. The maxillary nerve carries sensory information from the lower eyelid, cheek, nares, upper lip, upper teeth and gums, palate, the maxillary, ethmoid, and sphenoid sinuses, and portions of the nasal mucosa and meninges. The mandibular nerve carries sensory information from the lower lip, lower teeth and gums, the chin and jaw, parts of the external ear, and parts of the meninges. One of its branches, the lingual nerve, helps carry the chordae tympani fibers that are responsible for taste in the anterior two-thirds of the tongue. The motor branch of the mandibular nerve innervates the following muscles of mastication: the masseter temporalis, medial and lateral pterygoid. The ophthalmic, maxillary, and mandibular branches enter the skull through three separate foramina: the superior orbital fissure, the foramen rotundum, and the foramen ovale. These three branches converge to form the trigeminal ganglion, also called the semilunar ganglion or Glycerol ganglion, located within Meckel's cave. The trigeminal ganglion can be percutaneously accessed through the foramen ovale. The trigeminal ganglion is analogous to the dorsal root ganglion of the spinal cord, since it contains cell bodies of incoming sensory fibers. The trigeminal ganglion forms a single large sensory root that passes through the porus trigeminus to enter the brainstem at the level of the pons. Part of this proximal root includes a smaller motor root that emerges from the pons at the same level. Cell bodies of these mandibular motor fibers are located in the motor nucleus of the trigeminal nerve deep within the pons. All sensory information from the face, including information transmitted by other cranial nerves such as 7, 9, and 10, is relayed to the trigeminal nucleus. The trigeminal nucleus extends throughout the entire brainstem and continues into the upper cervical cord, where it merges with the dorsal horn of the spinal cord. The nucleus is divided anatomically into three parts, visible in microscopic sections of the brainstem. From caudal to rostral, these divisions are the spinal trigeminal nucleus, the principal or main trigeminal nucleus, and the mesencephalic trigeminal nucleus. These three divisions of the trigeminal nucleus receive different types of sensory information. The spinal trigeminal nucleus receives pain and temperature information. The main trigeminal nucleus receives fibers responsible for discriminative touch. The mesencephalic nucleus receives proprioceptive and mechanoreceptive fibers from the muscles of mastication. The pathway for pain transmission from the face to the cortex consists of three neurons. The first order neuron is located in the Glycerol ganglion and connects peripheral nociceptors in the face to a synapse on the spinal nucleus and is visualized in this slide. The second order neuron for facial pain transmission arises from the spinal nucleus and crosses the midline to join the ventral trigeminal thalamic tract. As depicted, this tract projects to the contralateral ventral posterior medial nucleus of the thalamus. The third order neuron for facial pain transmission arises from the ventral posterior medial nucleus of the thalamus and travels through the genu of the internal capsule to arrive in the primary somatosensory cortex of the parietal lobe. Trigeminal neuralgia is usually caused by demyelination of trigeminal sensory fibers residing within the dorsal root entry zone, which represents the junction between central and peripheral myelination of the axons. In approximately 85% of cases, this demyelination is secondary to compression caused by an artery or vein. Other causes of trigeminal neuralgia in which demyelination is implicated include multiple sclerosis or compressive lesions in the posterior fossa. Examination of trigeminal nerve roots from patients with vascular compression of the nerve reveals focal demyelination in the region of the compression. This is illustrated in the lower right part of the slide by a toluidine blue stained section through a zone of demyelination within the nerve from a 2001 paper in Brain from Love et al. Similar foci of nerve root demyelination have been described in multiple sclerosis patients with trigeminal neuralgia. Experimental studies indicate that this anatomical arrangement favors the ectopic generation of spontaneous nerve impulses and ephaptic conduction to adjacent fibers. Decompression often produces rapid relief of symptoms, and relief of symptoms is believed to be sustained with remyelination. The clinical history is essential to the diagnosis of trigeminal neuralgia. In its classic form, trigeminal neuralgia involves a unilateral, lancinating, or electrical pain in one or more of the trigeminal nerve distributions. Patients usually describe trigger points on the face and activities that result in reproduction of pain. Patients with trigeminal neuralgia can often detail the memorable onset of the pain. Trigeminal neuralgia has variable periods of remission, and most patients describe some element of pain relief from anti-epileptic medication like carbamazepine, gabapentin, and phenytoin. Baclofen may also result in improvement. Carbamazepine, or Tegretol, in particular offers acceptable relief in approximately 70% of patients. Furthermore, patients on this medication should be intermittently monitored for development of leukopenia or changes in liver enzyme profile. Although not usually clinically significant, the cutaneous perception of sensation and light touch is often slightly impaired on the symptomatic side. The physical exam of a patient with trigeminal neuralgia should include formal assessment of sensation in all three divisions of the trigeminal nerve. Specifically, one should assess whether the corneal reflex is intact. A complete neurological exam, especially of the remaining cranial nerves, is necessary to assess for neurologic abnormalities that might indicate other pathologies, such as multiple sclerosis or posterior fossa masses. In atypical trigeminal neuralgia, patients often describe unilateral pain which involves the trigeminal nerve distribution that is burning or aching in character. Occasionally, there is a history of damage to the nerve, either from surgery, viral infections, or trauma. Usually, clinically evident sensory loss in the affected nerve distribution is often present, and facial discomfort is often continuous or nearly continuous. Moreover, patients with atypical trigeminal neuralgia rarely respond to any of the aforementioned anti-epileptic medications that are often effective in trigeminal neuralgia. Some patients with atypical trigeminal neuralgia will have previously suffered from typical trigeminal neuralgia that has progressed over the years. A diagnosis of atypical trigeminal neuralgia has a worse prognosis with any intervention compared to typical trigeminal neuralgia. In an extensive review by Tyler Cabrera et al., in over 2,000 patients undergoing microvascular decompression, 80% of patients with typical trigeminal neuralgia had significant pain relief at 5 years, whereas only 51% of patients with atypical trigeminal neuralgia had similar results. A classification scheme by Birchall et al. Published in 2003 divides facial pain into several distinct categories. In this classification system, trigeminal neuralgia type 1 refers to patients who experience the spontaneous onset of episodic facial pain. Trigeminal neuralgia type 2 refers to patients with a constant component of facial pain consistent with an aching or burning character greater than 50% of the time, previously referred to as atypical trigeminal neuralgia. Trigeminal neuropathic pain results from unintentional injury to the trigeminal nerve from trauma or surgery. Trigeminal deafferentation pain results from injury to the nerve by unintentional destructive procedures during prior treatment of trigeminal neuralgia or other facial pain. Post-herpetic neuralgia is chronic facial pain that results from an outbreak of herpes zoster, usually in the ophthalmic division of the trigeminal nerve. This pain usually occurs in elderly patients. Atypical facial pain is facial pain secondary to a somatoform pain disorder. This final category is usually diagnosed following formal psychological analysis. Again, for a thorough description of the trigeminal pain syndromes under this classification, please refer to the article by Burchell et al. In the November 2003 edition of Neurosurgery. Most neurosurgeons advocate MRI in all patients with trigeminal neuralgia in which surgery is planned. When history and clinical exams suggest the possibility of multiple sclerosis and/or a mass lesion, MRI of the brain may be helpful in determining what lesions may or may not contribute to the patient's complaints of facial pain. Although standard coronal T1 weighted spin echo MR images obtained with 3 mm section thickness will demonstrate mass lesions, they do not have sufficient detail to demonstrate vascular contact with the trigeminal nerve. Newer MRI sequences, such as Fiesta sequence, allows for visualization of vascular structures with high signal intensity, an effect that can be further emphasized with gadolinium enhancement. Another advantage of these protocols is the ability to acquire data with very small effective section thickness, which limits the effect of volume averaging. These sequences have been demonstrated to be more accurate in detection of vascular compression than standard spin echo techniques. In general, treatment of trigeminal neuralgia can be stratified into destructive and non-destructive modalities. The first group of treatments essentially interrupts or intentionally alters the sensory pathways of the nerve. These modalities include radiofrequency lesioning, balloon compression, glycerol rhizotomy, and radiosurgery. These treatments for trigeminal neuralgia, although generally less invasive than microvascular decompression, are associated with higher risks of recurrence of pain. However, these methods are usually outpatient procedures and avoid the risks of craniotomy. To perform a radiofrequency lesioning, the patient is placed in a supine position on the operating room table and short-acting sedation is administered. A percutaneous approach is started 2.5 centimeters lateral to the oral commissure. The surgeon aims for the medial aspect of the pupil and 3 centimeters anterior to the tragus. Basically, an 18-gauge cannula is guided submucosally toward the intersection of the plane passing through the point 3 centimeters anterior to the tragus and the plane passing through the medial aspect of the pupil. Oblique or lateral fluoroscopy is often used in order to direct the needle placement into the foramen ovale. Once in the proper location, the needle is connected to a radiofrequency generator and radiofrequency current is passed through the needle tip in order to heat it to a temperature ranging from 70 to 85 degrees centigrade. The goal of this surgery is a controlled injury of that part of the trigeminal distribution affected in the pain. In a 20-year study by Tronier et al., there was a 50% risk for recurrence of pain 2 years after percutaneous radiofrequency rhizotomy. In comparison, 64% of patients who underwent microvascular decompression remained completely pain-free 20 years postoperatively. Results from multiple large series of radiofrequency lesioning demonstrate high rates of initial pain relief. Complications, however, include dysesthesia and masseter weakness. Minor dysesthetic complications range from 12 to 19%, while major dysesthesia, including anesthesia dolorosa, occur in 0 to 4% of patients in this report. Further details about radiofrequency lesioning are provided in a comprehensive review by Mullen and Lichter in 1983 introduced a percutaneous method able to compress the trigeminal ganglion and retroglycerine rootlets using an inflatable balloon-tipped catheter introduced through a cannula into Meckel's cave. The procedure is accomplished much in the same way as radiofrequency lesioning, although general anesthesia is often employed. The caliber of the needle is often larger than used in radiofrequency lesioning in order to accommodate the balloon catheter. In the procedure, a 14-gauge cannula is advanced into the foramen ovale with fluoroscopic guidance. A Fogarty catheter with balloon is inflated in Meckel's cave with about 0.7 cc of contrast medium until it resembles a pear or dumbbell shape. Inflation is maintained for 60 to 120 seconds. In comparison to radiofrequency lesioning, the rates of postoperative corneal anesthesia appear to be lower. However, selectivity of the lesioning effect is less precise. Hackinson described the technique of percutaneous Glycerol rhizotomy in 1981. The procedure is accomplished in a similar fashion as the other percutaneous methods. The patient is completely sedated throughout the procedure. A smaller needle is usually used, approximately 22 gauge. The goal of the procedure is chemical damage of the retroglycerine rootlets secondary to injection of glycerol in the trigeminal cistern. In order to maintain glycerol in contact with the trigeminal nerve for as long as possible, the sitting position is often employed, which can be difficult in an anesthetized patient. Cisternography is also performed via injection of contrast medium and is verified using fluoroscopy. Sterile glycerol mixed with tantalum is injected intracisternally. The patient is kept seated upright with head slightly flexed for approximately 1 hour time. The complications of glycerol rhizotomy include postoperative dysesthesias, corneal anesthesia, and perhaps anesthesia dolorosa, and they have been reported less frequently than other percutaneous methods. But the results of this procedure are the most variable reported in the literature. It is probably due to the increased complexity of the procedure in comparison to radiofrequency lesioning or balloon compression. Stereotactic radiosurgery, also known as gamma knife radiosurgery or linear accelerator radiosurgery, has been advocated as a minimally invasive alternative surgical approach to microvascular decompression, or the percutaneous surgeries for trigeminal neuralgia. For these procedures, a single 4 mm isocenter is often used for targeting. The target is 3 to 6 mm anterior from the junction of the trigeminal nerve and pons. At this location, the brainstem edge is irradiated at the 20 or 30% ISO dose line. Past patients have received maximum doses varying from 60 to 90 gray, with 80 gray being the most common maximal dose. Radiosurgery appears to have a lower risk of complications, such as facial paresthesias or facial sensory loss, than other destructive options. Complete pain relief following stereotactic radiosurgery is achieved at a median time of 2 months, with most patients achieving this level of relief within 6 months. In the largest series to date, approximately 56% of patients maintain more than 50% of pain relief at the time of follow-up, which was 5 years following the procedure. These results are reported by Kanzioka et al. In 2002. Microvascular decompression is the only procedure whose goal is to expose the pathology and treat it while preserving the integrity of the nerve. The largest contemporary series of published microvascular decompressions for trigeminal neuralgia is from Dr. Janetta's group at the University of Pittsburgh. These investigators followed 1,155 patients over an average of 6.2 years following microvascular decompression for trigeminal neuralgia. At 10 years following surgery, 70% of patients were completely pain-free and off medication. The vast majority of patients who failed microvascular decompression did so within the first 2 years postoperatively. Beyond 5 years post-op, the rate of recurrence was 1% per year. The postoperative complication rates observed by this group were low. The overall mortality was 0.2%. Chemical meningitis, defined as self-limited, non-infectious meningismus, was observed in 17% of the cohort. Other complications, including facial numbness, cerebrospinal fluid leak, hearing loss, or transient facial weakness, were less common and less than 2% for each category. In another study by Theodosopoulos et al., 76% of patients at mean follow-up of 57 months reported no symptoms. Correct positioning of the patient is one of the most important aspects of microvascular decompression surgery. At Vanderbilt, we choose to do the following. After induction of general anesthesia, the patient is placed in cranial fixation pins and moved to the lateral park bench position with the affected side placed up. Sometimes a lumbar drain is inserted prior to the incision to aid in drainage of cerebrospinal fluid and cerebellar relaxation. The head is rotated away from the affected side and the neck is flexed slightly so that the planned surgical trajectory approaches the cerebellopontine angle from a more vertical trajectory. It also helps if the vertex is slightly tilted down so that the mastoid assumes the highest position in the surgical field. It is also important to ensure that there are no significant compressions of the venous drainage from the head. Brainstem auditory evoked responses and facial nerve monitoring is frequently used to warn of excessive traction on the 7th and 8th cranial nerve. Once positioned and prior to prepping and draping, external landmarks are assessed. It is important to anticipate where the transverse and sigmoid sinus is in relationship to the approach into the upper CP angle. The transverse sinus is usually present along a trajectory from the external auditory canal to the inion. The sigmoid sinus usually lies within 1 finger breadth of the posterior aspect of the ear. The craniotomy, therefore, should expose the dura in a retrosigmoid region. A curvilinear incision is drawn out approximately 2 finger breadths behind the ear for the length of the ear. The patient is prepped and draped in the usual fashion. The incision is carried down to the bone using a scalpel and monopolar cautery. Self-retaining retractors are placed. This illustration was obtained from Roten's 2003 article in Neurosurgery. A 3 cm craniotomy or craniectomy is then performed, being careful to avoid injury to the venous sinuses. Once the transverse and sigmoid sinuses have been exposed extradurally, the bone edges need to be waxed thoroughly. It is important to drill far enough posteriorly to allow enough room to retract the cerebellum to visualize the CP angle. The dura is opened in several leaves and tacked up with small sutures. It is important to carry the durotomy as close to the sigmoid sinus as possible to reduce the need for significant cerebellar retraction and to be able to see the trigeminal nerve adequately adjacent to the petrous apex in the upper part of the CP angle. After the dura has been reflected, the cerebellum is gently retracted medially. At this point, patience is required to allow time for cerebrospinal fluid to egress, resulting in gentle relaxation of the cerebellar hemisphere. With the cerebellum relaxed, a retractor can be advanced to expose the superior petrosal vein. This vein typically is sacrificed in order to see the trigeminal nerve more adequately. However, in each case, the surgeon must decide the value of sacrificing significant venous structures for improved visualizations, since the risk of complications increases with decreased venous drainage. As the upper CP angle is exposed, the 7th and 8th nerve complex comes into view. During this exposure, vigilant attention is always given to the location of the 7th and 8th cranial nerves, since these two nerves are very sensitive to mechanical trauma or traction. We find brainstem auditory evoked responses are an essential monitoring tool to provide early warning of excessive traction on the 7th and 8th nerve complex. Microscissors or an arachnoid knife are used to open the arachnoid around the trigeminal nerve. The nerve and vessels are inspected circumferentially. Inspection of the trigeminal nerve begins at the site of the brainstem exit and proceeds distally along the nerve. Typically, the offending vessel is large and indents the nerve. The most common vessel found in trigeminal neuralgia is a rostroventral loop of the superior cerebellar artery. This vessel was the causal agent of compression in 53% of our patients. Other vessels include the anterior inferior cerebellar artery or large veins that drain to the superior petrosal sinus. After the causative vessel is identified, it is dissected and mobilized carefully away from the nerve. One or more small pieces of Dacron felt or Teflon is then placed between the vessel and the nerve to protect the trigeminal nerve. Following decompression, the nerve is re-examined on all sides to be certain that no additional compressing vessels are present. Here is a video illustrating the trigeminal nerve after decompression and placement of the pad. Note the adherence of the vessel with the nerve and the indentation of the nerve by the superior cerebellar artery. After microvascular decompression is performed, the wound is then irrigated gently and the retractors are removed. The dura is then closed. If a craniectomy was performed, the defect is completely filled with cement. If a craniotomy is performed, the bone piece is placed back in the defect, secured usually with a cranial plate, and the remaining defect filled with cement. The muscle and skin is then closed in several layers. This concludes the talk on surgical options for the treatment of trigeminal neuralgia. Thank you.